Gives me great pleasure today to introduce our speaker, Dr. Andre Isaac. Andre obtained his medical degree from the University of Alberta here, and then while doing his residency at the U of A in ENT, or otolaryngology, head and neck surgery, he also completed a master's in science and global health policy from the London School of Hygiene and Tropical Medicine. In 2019, he completed an advanced surgical fellowship in otolaryngology, head and neck surgery, focused on airway reconstruction and pediatric head and neck surgery at Lurie Children's Hospital in Chicago and Northwestern University. At the completion of his fellowship, he was appointed Associate Professor of Surgery here at the Faculty of Medicine and Dentistry at the U of A. Since 2015, he's been an Innovations Lab Director for ICC, or Innovative Canadians for Change. Many of you will be familiar with this. And since 2019, he's been an associate editor of the journal Otolaryngology, Head and Neck Surgery. He's an executive member of the Office of Global Surgery here at the U of A, and his clinical and research interests are related to pediatric open and endoscopic airway surgery, as well as global surgery in resource limited settings. And finally, he's the director of the U of A, is it MORE or MOA, Otolaryngology Surgical Partnership, sustainable model for surgical global surgical care in Western Kenya, where Dr. Isaac has worked. So Dr. Isaac, great to have you, and the floor is yours.
Awesome. Thanks so much, Dr. Lane. That was a very lovely introduction. It makes me sound a lot more important than I am. So, okay. All right. So it's a great pleasure to be able to talk today, and thank you so much for the invitation. I want to speak today about opportunities and kind of the changing landscape of global health and the role for global surgery, and some of the work that our group has been doing over the last few years and trying to advance the Office of Global Surgery here at the University of Alberta and internationally as well. So thank you all for attending, and I'm happy to take questions verbally at the end. If you want to post them in the chat, I'll check it at the end, and we can run through. Hopefully, we'll have lots of time for questions. Oops. So I know that there's probably a bit of a mixed audience, and I know a lot of people that are probably very much more well-versed in this topic than I am. But I want to give a little bit of background about the changing landscape of global health and the emerging role for global surgery in international development. And so over the last 10 to 20 years, the landscape of global health has changed. And whereas communicable infectious diseases and maternal and child neonatal health has dominated the global health landscape for decades, non-communicable diseases, in particular cancer and trauma, have become one of the leading causes of disability-adjusted life years worldwide, including in low and middle income settings. So what do we mean by non-communicable diseases? Well, the top five by far are cancer, cardiovascular disease, chronic respiratory disease, diabetes, and trauma. And these together accounted for 38 million deaths in 2012. Those numbers have been growing each year, projected to increase to 52 million by 2030. This is not just the disease of the elderly, as more than half of these deaths occur in people under the age of 65. And it's also not just a disease of high-income countries. So more than 80% of non-communicable disease deaths occur in low and middle income countries, where it's the number one killer and the number one cause of disability-adjusted life years worldwide. So many people will recognize these 8 very lofty goals. These were the Millennium Development Goals that were developed by the UN just before the turn of the millennium. And although these are much more kind of a historical topic right now, they very much represent the traditional approach to global health. And there were 3 main goals that were developed in the late 90s that were focused on health, mostly about reducing child mortality, maternal health, HIV, AIDS, malaria, and quote, other diseases, unquote, whatever that means. So, a lot of people had heard about these in the early 2000s and kind of 2010s, and maybe don't really know where we are with these goals anymore, or what's changed, or what the new landscape looks like. So in 2015, a lot of, the UN released a kind of statement of where we were with these goals. And I want to just highlight what's been done on those three important kind of health goals earlier in the 20th century, earlier in the millennium. And so a lot of these goals, none of them had actually achieved their intended targets, but did significantly have advancements. And so the global number of deaths in children under the age of 5 went from 12.7 million in 1990 to under 6 million in 2015. The global maternal mortality ratio decreased from 380 per 100,000 live births in 1990 down to 210 in 2013. Number of births attended by skilled health personnel had increased. There was a huge interest in treating HIV, AIDS, malaria, and other infectious diseases worldwide. There was an explosion of the number of people that were on antiretroviral therapy between 2003 and 2014. So a lot of these kind of three areas really dominate the global health landscape. And although they continue to be extremely important, a lot of people's focus has shifted to a wider view of what global health means now. And so these are, as many of you would recognize, the Sustainable Development Goals. These were developed as a kind of a continuation of Millennium Development Goals. And there's one major health goal, which is goal number 3, which says ensure healthy lives and promote well-being at all ages. And there's a lot of sub goals in there. And with the development of the Sustainable Development Goals came this emerging role for surgical care and the recognition of the importance of surgery in global health. So at the same time as the SDGs came out, the Lancet Commission on Global Surgery was released. I think this was around 2010. That basically carved out the definition, the role for global surgery, and came up with a number of overarching principles, mission statements, and general objectives for what they wanted to see global surgery do by 2030 with measurable targets. And so what is the global burden of surgical disease? Well, there's 1.5 billion people that lack access to safe, affordable surgical and anesthesia care when they need it. In rural settings of low-income countries where the deaths are the highest, 30% of deaths, it's estimated, could be averted by timely surgery. There were 17 million lives lost due to surgically treatable conditions in 2010 alone. And more than almost 3/4 of surgical care worldwide is provided in high and middle income countries, whereas the poorest 1/3 of the world receives less than 5% of surgical care. In terms of the financial burden of surgical disease, there's more than 30 million individuals will face catastrophic health expenditure due to payment for surgery and anesthesia every year. And 1/4 of all people who have a surgical procedure will face financial catastrophe as a result of seeking care. And this is both in high and low income countries. There's a common misconception that surgery is not cost effective, or that anything that's treated with a scalpel is a lot more expensive than anything that's treated with a pill. And although that can be true, the reality is a lot more complicated and nuanced than that. So if low and middle income countries were to scale up surgical service at an annual rate of 9% to reach a target of 5,000 procedures per 100,000 population, which is what was set out in the Lancet Global Commission, total cost was estimated, this is in 2010, to be $420 billion. Whereas the lost output just by GDP alone, based on disability adjusted life years from those conditions by 2030 is about $12 trillion. It's estimated that it costs $11 per each of 33 DALYs that are averted with providing basic anesthetic and surgical care. And if you compare this to detection and home treatment of acute respiratory tract infections, that costs about $20 per disability adjusted life year averted. Basic surgery is in fact more cost effective than antiretroviral therapy, even assuming high compliance and low cost of production. And although these numbers change constantly, and we're talking about very basic surgical and anesthetic needs, the surgery is a lot more cost effective in low and middle income countries than it's commonly thought. So with that kind of background on the kind of emerging role and recognition of surgery in the global health landscape, I wanted to talk about 3 main questions that I think are common misconceptions about the role for surgery. So number 1, what actually is global surgery? What do I mean by those words? who does global surgery, where are the people involved, and why should you get involved in this type of work? So I want to go through some of these areas by talking about one of our missions called the U of A Moy Otolaryngology Surgical Partnership. And we're going to go over some of the specifics of the work that our otolaryngology team has been doing there for the last number of years. And then maybe talk about some of the principles using this as a potential model for how to develop a sustainable surgical development program in a low resource setting. So we work in Kenya. Kenya is a large country, and despite its large size and population, there are only two main tertiary care publicly funded referral hospitals in the country. One of them is called Kenyatta National Hospital in Nairobi. This is a behemoth of a hospital with more than 1,000 beds. It is one of the largest hospitals in East Africa. The only other center is Moi Teaching and Referral Hospital. It's a publicly funded tertiary care center, which is meant to service Western Kenya and Eastern Uganda and northern parts of Tanzania. So this is about a hospital about the size of the Misericordia that services a population of about 30 million people as the only public tertiary care center. This project was done at Moi through a combination of partnerships between the Office of Global Surgery at the University of Alberta, our NGO, which is called Innovative Canadians for Change, which I'll talk about a little bit later, and the AMPATH Consortium, which is a consortium of universities headed by Indiana University in the US that work in East Africa, as well as a number of other locations across the world. And AMPATH, I don't want to give the impression that we had reinvented the wheel with this. AMPATH had been building the infrastructure for these types of projects at this hospital for a number of years, which we used as a vehicle to deliver this surgical care. So the initial team involved a number of head and neck surgeons, otolaryngologists, as well as a head and neck pathologist. This team has grown over the number of years that we've been doing this. Our initial objective when we first went to evaluate this area a few years ago was to perform a formal needs assessment based on the WHO hospital model about the personnel and training that's provided at Moi Teaching and Referral Hospital in terms of otolaryngology, look at the equipment, supplies, and infrastructure, their patient workflow and volume, referral pathways and triage systems, and patient community resources. And the objective of our first surgical mission that we went there was to just establish some relationships with local surgeons and perform a limited number of surgical teaching cases. And so some pretty modest goals that the surgical team at Moi had expressed interest in learning or expanding their repertoire so they could better treat the extremely large catchment area that they service. So Moi Hospital is in Eldoret in Western Kenya. I'm going to dive right into what things are like at Moi. This is one of the main otolaryngology theaters at Moi. It's actually, despite some of the infrastructure being lacking, it's actually pretty well equipped with a lot of the same equipment or basically older versions of everything that we would have in Edmonton. Our principles there are we're always working with the local team and the local infrastructure and local surgeons. So a lot of these surgical mission models involve kind of a parachute approach of operating, bringing your own OR nurses, your own OR equipment, and maybe doing some teaching with local people that they could never really reproduce without you there. So we try to make a habit of not bringing anything that can't be sustained at hospital in Moi and working with what's available. This is Dr. Al-Raji doing an airway case on a pediatric patient with instruments that I don't think we've seen here for decades, but it actually goes to show you how with a little bit of innovation and you can perform a large number of surgical procedures with very limited resources and pretty rudimentary infrastructure. Just I have some photos of kind of the post-operative care areas and the ward beds at Moi Teaching and Referral Hospital. So a typical kind of middle-income country hospital where patients are often sharing beds. Often you have pediatric and adult patients in the same wards. So relatively limited resources. I want to go through a few of the kind of lessons learned from our first round there of doing some surgical cases and identifying some areas for improvement, and how this has fed the development of this model that we've tried to replicate in other areas. So as you can imagine, the surgical volume at a place like Moy is overwhelming, and I think the initial reaction to people that head there, even that people that are maybe experienced in the specialty or experienced in even doing these types of care in low resource settings, are even often kind of shocked and overwhelmed about the sheer volume of patients, the late presentations and late diagnoses that you'll see, and it often hits people right away. And so the first day that we go to this mission, it's almost always about 100 to 150 patient clinic, which is really a fraction of the number that the team there really wants us to see, or that we could see. And a large proportion, unfortunately, present like this. This is a young gentleman in his 20s with a large nasopharyngeal carcinoma that unfortunately was palliative due to a late diagnosis and invasion of the orbit. Another, young girl that had an unfortunate rhabdomyosarcoma of her skull base, all diseases that are surgically treatable, that often come to us late and unfortunately are palliative in the vast majority of cases that present there. A lot of the issues are also just limited by a lack of tools and infrastructure. So this is kind of a lesson we learned initially when we went there. We didn't have a lot of kind of pre-clinical planning in terms of the types of cases we were going to see. This is a young boy with a fibrous dysplasia of his skull base, who's actually treatable. This is not a malignant lesion, but they just don't have the tools to be able to manage something like this there. And so this disease is just going to progress and progress and progress. This is a patient that we operated on the second time we went, after we were able to get the right tools and plates to be able to treat this kid. Everybody who operates in Eastern Africa is going to be very familiar with thyroid disease, and I would like to say that this is the largest thyroid goiter that was in the hospital that day, but this is about the average patient. And so a lot of the surgeons there, may be comfortable with some of these procedures, comfortable with thyroid surgery, for example, but are, ill-equipped or uncomfortable with maybe managing some of the more advanced diseases and advanced cases. And with just a little bit of kind of training and some hands-on work, can be able to manage a whole host of conditions that don't require us being there. One of the main limitations at Moy, which is a common problem that you'll see in these types of hospitals, is the limits on pathology due to the limited number of stains they can do, immunohistochemistry, and sometimes just trained personnel to be able to manage these cases. And this can be a huge problem from a surgical perspective. So this is a young 16-year-old girl that we did treat while we were there, with this, pretty aggressive looking lesion coming out of her parotid gland on the right side here. And this photo just demonstrates that she's got some facial nerve paralysis on that side. And this was biopsied multiple times, and we were told that this was a mucocele, and a mucocele is a very benign lesion that basically is just some extravasation of some salivary fluid in a parotid gland. And this is definitely not what this is. And so without having accurate pathology, the right stains, it's really hard to come up with surgical management plans for patients when you don't know what you're dealing with. This is a clinical scenario that had come up while we were there. And I'm going to get a little bit technical here with some of the details, but suffice to say that one of the things we manage as otolaryngologists is airway emergencies. And a lot of the issues that we found coming up were just kind of a lot of basic training issues with the anesthesia and the airway team there. So this was a 40-year-old woman that had a very large base of tongue mass. And she came in some respiratory distress and some acute airway obstruction. from our perspective, from an airway surgery standpoint, you need to have a good plan for how you're going to manage that airway. Number one, you need to have appropriate number of backup plans, the appropriate people in the operating room before you go ahead and tackle this type of case. And from the anesthesia perspective, this case was actually happening next door, and we weren't actually even involved in the case, and we kind of heard some commotion going on and popped in to see what was going on. And the anesthesiologist's first inclination was to push a bunch of propofol and put this patient to sleep. And we said, well, why are you going to do that? Like, there's nothing, in the room here. I don't think that's the safest option. And their thing was, well, her airways obstruction, she needs to go to sleep. That's the appropriate step. And so from an airway standpoint, that's probably the last thing that should have been done first on a patient like this. And so a lot of the issues that we found when we were trying to deal with maybe some advanced surgical cases, that some of the very basic training in terms of airway management really weren't there. And these are really easily fixable problems. These people are all they're all skilled, they're all eager to learn, they're all extremely intelligent and capable, and with a little bit of kind of training and direction can really kind of transform surgical care at this site. I was just kind of pointing out here that this patient, and again, maybe this is a little bit technical for some of the kind of non-medical people here, but the patient doesn't have a SAT monitor on. The patient doesn't have, we don't have end tidal hooked up. We don't know what the patient's respiratory rate is. We don't know what the patient heart rate is. And this is kind of what we walked into as the anesthesiologist was trying to intubate this patient. This lady did fine. This is an example of one of the more areas where we tried to push the envelope in terms of surgical care that we do in Moy. So this is a 77-year-old woman with a poorly differentiated carcinoma of her parotid. This is an advanced disease, but this lady was actually quite healthy, had really no other medical problems other than this parotid cancer. And this is a very surgically treatable condition. So a lot of the team there would look at, a patient like this and say, well, this is palliative, but really this is quite treatable. It's quite treatable relatively easily. And a lot of the issues that they had was they could do a lot of surgical resections, but reconstructing things in terms of functional reconstruction was a big challenge for them. So this is one of the bigger cases that we tackled, where we did a total parotidectomy and a pec major flap, local regional flap reconstruction of the area. And basically with single modality therapy, this patient was cured. But again, some of the subtleties of, you can do some pretty complex stuff here, but some of the issues are just around basic medical management of these patients can cause some issues. So for example, during this procedure, we were worried that during the raising of her pec muscle, we were worried that she might have had a pneumothorax, which for maybe some of the non-medical people just means some air collecting outside of her lung between the lining of the lung and the chest wall. And so that's a treatable condition, but something that needs to be managed right away. And so, we wanted to get a chest X-ray intraoperatively. That wasn't available. So they said, okay, we'll do it in the recovery room. So this is her in the recovery room, and she's doing pretty well here. And some of just the kind of basic first principles can get you into trouble here. So this is a woman, she's 77 years old. Eldoret is a pretty high altitude. In fact, it's actually like a very big destination for marathon runners. So to see somebody satting 100% on room air, who's 77 years old, that had just come out of surgery, that found that a little bit hard to believe. And so I'm like, how is she satting at 100%? There's no way that's actually happening. But if you look at actually what's happening here, and you follow the probe, this SAT actually corresponds to the patient that's sitting next to her, who actually is on oxygen. And so, one of the residents went to check on this patient and said, oh, she's doing great. She's breathing fine. She's satting 100%. And some of the most, little tiniest issues that wouldn't happen here can run you into big problems there. Okay, so what came from our initial needs assessment at Moy Teaching and Referral Hospital? Well, they have a total of 4 otolaryngologists who are all trained in Nairobi. The department is mostly run by clinical officers, which are 6 of them, which are basically kind of the equivalent of clinical associates, how they work at the in Edmonton. They have an overwhelming volume of head and neck and complex ear disease cases. Majority of complex cases are referred on to Kenyatta National Hospital. And that's a major barrier for a lot of patients at this area, because a lot of them don't have the capacity or funds or means to be able to travel to Nairobi. Kenyatta is a massive bit of bureaucracy and infrastructure, and even getting a referral there is a very long process. There's a lack of training for complex head and neck resections and local regional reconstruction, a lack of comfort with complex otology or ear disease, and a lack of capacity and training for laryngotracheal reconstruction, which we'll talk about in a little bit here. There were some major deficiencies in difficult airway management with anesthesia training and comfort. Intraoperative emergency communication was a problem we found, inadequate and inaccurate pathology, and there were specific equipment deficiencies which caused a lot of problems. So I give this as an example. This is their ear microscopes, and these are really necessary for a lot of otologic cases, basically any complex ear case you need a microscope for. This is actually a relatively nice microscope. The problem with this is that hospitals like this often get equipment like this donated from high income countries or centers that don't need it anymore. And the problem with that is that these machines are very complex in how they work. There's a lot of moving parts, and they're very difficult to fix. And so these even though this microscope worked, this microscope is about 25 years old and is made by a company that doesn't exist anymore. And frankly, even if the company did exist that makes this microscope, there's no way they're going to be able to service this microscope. So the tiniest little thing happens, the tiniest little part breaks, and this microscope is gone. It's hooped. Nobody can fix this thing anymore. And so it's not as helpful as one would think to donate all this really fancy or really good equipment, even if it's in good working order, if you can't guarantee that it can be upkept and it can be maintenance there. So it's actually way more cost effective to buy a brand new microscope that can actually be serviced and is under warranty than to donate one of these microscopes every 5 years because it breaks every couple of years. This microscope actually broke while we were there. So I'll run you through some of the innovations that we tried to come up with to how to get around these types of issues. So this was the very first trip that we went on, and some of the operative and clinical patients that we did. And I go through this in detail when I'm talking mostly to otolaryngologists. I think this is going to be pretty boring, so I'm not going to go through what we did there. But from that, we developed a set of long-term goals, and the long-term goals were to equip Moy Teaching Referral with the ability to surgically treat all head and neck cancers that don't require free flap reconstruction and all mastoid disease. We wanted to equip the hospital with those tools and skills to perform pediatric and adult laryngotracheal reconstruction. I'll go through that in a little bit more detail about what that means later in the talk. We wanted to lay the groundwork for a residency training program at Moy, which is a big goal of a lot of the surgeons there and would really help for a lot of the manpower issues that they have. We wanted to equip the teams with techniques to safely manage difficult airways, improve and strengthen pathology there, and reduce reliance on complex and expensive equipment. So this is where innovations like endoscopic ear surgery come in, and I'll talk about that more in a moment. Specifically, this came in the form of a yearly surgical teaching and infrastructure support trip where we would pre-screen patients via pre-designed forms and photo documentation. We're working on developing an electronic medical record that's going to be supported by the jurisdiction in Western Kenya that we can get onto in Alberta. We have worked on a surgical training and fellowship exchange. We developed an international tumor board to be able to go over complex cases longitudinally with the team there in terms of surgical and non-surgical advice. We started a pathology training and biopsy clinic that we do every year that we go. So what we do now is we perform all our own fine needle aspiration and other biopsies when we're there, and have one of our pathologists go through them with the pathology department to be able to get some more accurate pathology. And this has been able to massively change the types and quality of the specimens that we're able to get, and the quality of the pathology that is able to inform surgical resections. We've created a formal region-wide airway course, which unfortunately we weren't able to deliver last year, which we'll talk about the whole COVID problem in a little bit here. We developed an endoscopic ear course and simulation lab, and I'll show you how that works in a little bit, as well as the laryngotracheal reconstruction lab. So in 2019, which was a few years into the trip, we started bringing the team at Moy started bringing residents along from the Nairobi otolaryngology training program to work with us in Western Kenya and do some cases with us, which is a huge help. Gentleman on the right here, his name is Dr. Ngoitsi. He's one of the lead ENT surgeons in Moy who helps coordinate our trip. And this is kind of a video of them learning endoscopic ear surgery. So this is kind of one of the innovations that we had tried to come up with. So ear surgery has almost always, for the last 100 years or so, required a microscope. And so in the last 10 to 15 years, people have started transitioning to using endoscopes to do ear surgery. Now, without getting into a lot of the technical details, this is a huge challenge, and mostly because everybody's trained to work in the ear with two hands. And when you're using an endoscope, which is this little telescope here, you have to learn how to operate with one hand. And that, for a number of years, although endoscopes are not a new technology, for a number of years that just detracted from people trying to learn this technique, or kind of just saying, no, this is impossible to do. But people have started to innovate, and in the last 10 to 15 years, this has become much more of a mainstream technique. And so this is the perfect type of technique that can be utilized in a low resource setting, because endoscopes are exponentially cheaper than microscopes. They're also much, much easier to fix. And so taking away the need for complex equipment, even if it's with a relatively new and innovative technique that you might not think would actually apply to a low resource setting, can be a huge benefit. So this is one of the Nairobi residents trying to learn some endoscopic ear surgery with me after we did a simulation lab. And by the end of the trip, this is about 2 weeks later, these guys are just incredibly bright and willing to learn. And he did this case completely by himself, which I've never seen somebody pick it up that fast, actually. I only bring up this photo because Dr. Pudigunta is one of the head and neck pathologists. Many of you may know her. She's absolutely brilliant head and neck pathologist at the U of A. This is the only picture I could ever get of her because she would never let me take her photo. So I had to put her in there. Okay, so one of the other concepts, and this is another kind of opportunity for innovation in a low resource setting, is laryngotracheal reconstruction. So what is this? So this is a stock photo from Lurie Children's Hospital where I did fellowship. Pediatric patients who have tracheotomies have a very complex and non-straightforward life. And in a place like the Stollery, we recognize that and sometimes take for granted how much resources that these patients require in the community. So especially if you require a ventilator, but even if you don't require a ventilator, the level of care that these, especially in infancy and their toddler years, the level of care that these kids need is quite astronomical. And we are relatively well set up to be able to take care of these kids at home. And it kind of comes as second nature about how these kids get managed. But if you look at a country like Kenya or a setting like Western Kenya, those resources in the community don't really exist. So in terms of infants that have a tracheotomy done or toddlers that have a tracheotomy, almost all those children either live in a hospital or live in these specialized tracheotomy orphanages because their parents aren't able to take care of them. And so the limiting factor in pediatrics is the is being able to get that trach out. And a lot of these patients require very complex operations to reconstruct their airways in order to get that tracheostomy tube out. I'm trying to gloss over a lot of details so I don't bore you guys. This is laryngotracheal reconstruction is kind of the end of the line in terms of complexity of pediatric airway surgery, both in the time it takes, the postoperative care it takes, the level of training it takes, level of expertise. And so you might think, well, what kind of role does that have in a setting with low resources where there's a lot of more basic techniques that we can't even do? Well, you have to kind of look at the bigger picture, because if you're somehow able to equip a center like this to be able to perform these operations, get kids' trachs out, get them home with a much lower level of support, get these patients back to their families, and which has shown them to be have a much more likelihood of, number one, long-term survival, and number two, being able to become kind of a functioning and working member of society later in life. That can actually be a huge resource burden that you take off the system. And so what we started working on is there's a number of very motivated surgeons there that they're not able to do these cases there right now. We've been working with a team in Toronto who's been designing simulations for laryngotracheal reconstruction to be able to do a yearly course on these techniques. And although the first cases we were going to do with the team there were supposed to be this last year, and obviously COVID has nicely messed all that up, as it has a lot of other things in life. But it's just another example of that people often think that in order to work in these centers, or in order to what these centers need are very basic, very kind of low fidelity, low resource techniques or skills. And although that is true, and sometimes I wouldn't count them out from being able to do these much more complex cases and complex reconstructions if you think about the overall long-term picture. So every presentation that I've listened to in the last, 18 months has had a slide about COVID. Doesn't matter what it's about. So obviously COVID-19 has greatly affected the how we deliver these types of care, and with a lot of the international travel restrictions, it's obviously limited us a lot. There's been a lot of innovations in being able to provide surgical care. When it comes to surgery, that's particularly challenging. Although there are some innovations we're working on with being able to do some virtual surgery and at least kind of intraoperative live consultations with some of the surgeons there. But obviously this is a work in progress, but has also created a huge area of opportunity for us to innovate as well without being able to travel to Kenya. So I'll come back to kind of the three questions that I talked about, and hopefully we've addressed some of these topics. So what is global surgery? Well, I hope that I've shown that this is more than going into a low resource center and operating. What we define as the Office of Global Surgery is a systems-based solutions to complex problems in resource limited setting to address barriers to accessing timely and safe surgical care. So it is a lot more than operating in a low and middle income country. And I think some of the most important and challenging parts of global surgery have nothing to do with the operating room. Solving these problems needs more surgeons involved. I don't think there are enough surgical people that get involved in global health because they think there's not really a role for them, because they've been told their whole careers that their jobs are too expensive and too resource intensive, and that's why there's no jobs here, yada yada yada. But I think that a lot of that is a myth, and it's changing. And that's where I think the role for the Office of Global Surgery has really come to the forefront in terms of advancing the role for global surgery at the University of Alberta. Who does global surgery? So I've also shown you that it's a lot more than surgeons. So this. When we think about a systems approach of addressing access to surgical care, this needs a lot of people involved, and it always does, from surgeons to pathologists to physicians to allied health professionals, health economists, hospital administrators, donors, volunteers that all have played an important role in a mission like the U of A Moy Otolaryngology Partnership and others as well. And why do this? So often one of the first questions I get after a talk like this, especially if I'm giving it to people who maybe don't know a lot about global health or aren't maybe versed in this topic, is, you know, how did you get into this and why do you do this kind of stuff? And so I'm gonna preempt that question, although I don't think I'd get asked it here because I think everybody is kind of like-minded in this setting. But you know, when you talk to people that have been doing this job a lot, a lot of I'd say you don't commonly get the answers that you think you're going to get. In fact, the most experienced people in these fields don't really say things like, "Oh, I really want to help people," or, you know, you know, my heart goes out to, you know, these people in these countries that can't access care. Yeah, that's all great, and that's all very motivating and a you know, a background factor, but that's not really what keeps these people coming to work and doing this every day. I think what keeps people motivated in this type of field is that it's a massive challenge, right? You're met with a different type of challenge every day. It's the opportunity to be an innovator and to come up with new and interesting solutions to really complex kind of age-old problems. Really pushing the boundaries on what's possible in terms of realizing how much you can do with a relatively small amount of, you know, money, time, infrastructure, training, whatever it is. It's an opportunity to build teams and partnerships. Some of the most interesting people I've ever met in my life I've met working on these types of things. You have the opportunity to build and design systems from the ground up sometimes, which is a huge opportunity for people that are really into systems-based thinking and really like to build these types of programs. And frankly, being involved in this work, I think everybody should be, because it makes you a better clinician. It makes you a better surgeon. It makes you a better physician, makes you a better nurse, makes you a better, you know, whoever, because being able to realize what you can do with relatively little makes you more innovative at your job. It makes you more lean in what type of resources you need and what you think you need. I bring up a picture of this guy as one of my last slides. So to be honest, I don't even remember his name anymore, but this was a surgeon that we met at Moy and Eldred in, I think, 2017. He is a transplant surgeon from the Netherlands. And we met him just in like the cafeteria of the hospital, I think, one time, and started, he struck up a conversation with us because he could tell we weren't from around there. And he told us his story about him and a bunch of his transplant team had been going to Moy and working with some of the general surgeons and the urologists there for the last 8 years, and had built a transplant program basically from the ground up, had built a kidney transplant program. And that was our first time that we were working in Moy, and the weight of how much work this was going to be was kind of dawning on us. And this guy was there for the very last time. So he said, "This year I've come with nobody, I've come with no team members, I've come with no tools. It's just me, and I'm, you know, hanging out outside the operating room in case they need help for the very last time. And then I never plan on coming back here again." And that was the one of the biggest success stories I've ever heard in one of these, you know, missions that you often hear about how they start and you don't hear about how they end. And this was now a fully sustainable, self-functioning transplant program that these guys have built over a course of 7 or 8 years, which is really just like a flash of time. So the boundaries of what's possible, even with relatively low resources, constantly are getting pushed all the time. So there's a lot of opportunities to get involved. Specifically, if you want to get involved in our type of mission, I'm happy to chat offline as well. We're always looking for new people, regardless of your level of training, your area of expertise. I'm happy to chat anytime. My email's at the bottom there. And I hopefully I've left a good amount of time for questions.